Ventilator-associated pneumonia. Ventilator-associated pneumonias, hereafter referred to as VAP, are among the most common hospital-acquired infections. These infections, which occur greater than 48 hours after mechanical ventilation is initiated, are associated with longer hospitalizations and intense resource utilization. Both under and over treatment of VAP can have detrimental consequences for individual patients, as well as on the emergence of resistance in your hospital. Thus, the optimal management of these patients is critical. VAP has an epidemiology distinct from that of community-acquired pneumonia. Evidence suggests that patients admitted to the hospital rapidly become colonized with nosocomial organisms, many of which are likely to be drug-resistant. VAP is most commonly due to these acquired nosocomial pathogens, not the patient's endogenous flora. Several factors contribute to each hospital's unique microbial ecology, including the number and types of patients cared for, the intensity of antimicrobial utilization, and the attention to infection control precautions. The emergence and establishment of drug-resistant organisms in a hospital, due in part to the widespread misuse of antimicrobials, jeopardizes all patients with nosocomial infections, including patients with VAP. Let's begin this module with a case. Imagine you are evaluating a 65-year-old female who was admitted to your ICU 4 days ago with severe congestive heart failure. Her hospital course has been complicated by respiratory failure, necessitating mechanical ventilation upon admission. This morning, she developed a fever to 38.7 degrees Celsius, and her nurse reports that she has required more frequent suctioning, almost every hour. Overnight, her oxygenation requirements have also increased, along with increased need for more ventilator support. Her blood pressure has remained stable. On physical examination, you note diffuse rhonchi bilaterally, as well as decreased breath sounds in her right lung base. Her white blood cell count this morning increased to 15,000 from 9,000 cells per millimeter squared 2 days before. You obtain a portable one-view chest X-ray, which shows a new right lower lobe infiltrate. How would you manage this patient? Let's discuss this case using the construct introduced in the introductory modules. First, how severe is this patient's condition? Her overall condition is severe, given her need for mechanical ventilation and ICU support. In addition, she is febrile, with focal findings suggestive of VAP. Although she is not hypotensive, optimal empiric antimicrobial therapy should be started as soon as possible in an attempt to prevent progression to septic shock. Next, what is the likely source of this infection and what are the likely pathogens? Nosocomial fever in the ICU requires clinicians to systematically consider their differential diagnosis. Often, patients are not able to describe localizing symptoms given their critical illness, need for mechanical support, and often sedation. In this case, the patient has several classic findings suggestive of VAP. She has increased suctioning requirements, increased oxygen and ventilator requirements, evidence of a systemic inflammatory response with fever and leukocytosis, and a new infiltrate on chest X-ray. Hospitalized patients readily become colonized with nosocomial pathogens and aspirate oropharyngeal organisms into their lungs. The most common bacteria associated with VAP are Staphylococcus aureus, both methicillin-sensitive and resistant, and gram-negative organisms, including the Enterobacteriaceae family, as well as Pseudomonas aeruginosa and Acinetobacter. The relative contribution of these organisms varies by hospital and sometimes even by unit within a hospital. How likely is this infection due to a drug-resistant organism? This too depends on the prevalence of drug resistance in your institution or hospital. Institutional cumulative antibiograms can be useful in determining the optimal empiric antimicrobial therapy. The 2016 Infectious Diseases Society of America and American Thoracic Society guidelines also include the following as risk factors for VAP due to multidrug resistant organisms: intravenous antibiotics within the last 90 days, septic shock at the time of VAP diagnosis, acute respiratory distress syndrome, and renal replacement therapy prior to VAP. These guidelines also recommend the consideration of the following when choosing an empiric antimicrobial regimen for VAP. They recommend to consider the risk of methicillin-resistant Staphylococcus aureus infection. These guidelines recommend empiric therapy directed at MRSA if the patient has received intravenous antibiotics within the preceding 90 days or the prevalence of methicillin resistance among Staph aureus isolates in your hospital or unit is greater than 10 to 20% or is unknown. These guidelines recommend prescribing 2 anti-pseudomonal antibiotics of different classes if the prevalence of resistance to one of these agents among common gram-negative pathogens in your hospital or unit is greater than 10% or is unknown. This broad coverage provides a greater chance of covering the etiologic organism with your empiric therapy, meaning if the pathogen is resistant to one agent, it may be susceptible to the other. If you choose to prescribe 2 agents for your patient in concordance with these guidelines, you must commit to de-escalating therapy as appropriate upon review of clinical and microbiologic data. Next, what patient characteristics must be considered? Dosing all medications in the ICU can be challenging as a result of altered volume of distribution, frequent fluid shifts, and fluctuating renal function and its management, among other considerations. One example is evidence of frequent underexposure to beta-lactam antibiotics as the result of increased volume of distribution and renal clearance in some critically ill patients with sepsis. And finally, do you need to obtain cultures prior to starting empiric antimicrobials? In this case, yes. Guidelines recommend blood cultures and semi-quantitative non-invasive respiratory cultures, such as endotracheal aspirates, for all patients with possible VAP. The blood cultures must be obtained prior to the initiation of empiric antibiotic therapy or before adjustments of pre-existing antimicrobial therapy being administered for other reasons. Blood cultures should be obtained via your hospital's standard protocol. Obtaining these cultures will prove critical to optimal decision-making in the next few days. Your patient has not received antibiotics recently, according to her family, and has not received any antibiotics earlier in this hospitalization, so she does not have a personal risk factor for infection with a multidrug-resistant organism. Let's assume you do have a cumulative antibiogram available, and the rates at your institution are higher than the threshold set in the American guidelines that we reviewed. You decide to start vancomycin for empiric MRSA coverage, preferably with a loading dose and a plan to maintain trough concentrations of at least 15 to 20 micrograms per milliliter per guidelines, as well as piperacillin tazobactam and levofloxacin as your 2 anti-pseudomonal agents. If resistance to fluoroquinolones or their potential role in leading to C. difficile colitis is problematic at your institution, the use of an aminoglycoside such as tobramycin is warranted in place of levofloxacin. You administer piperacillin tazobactam via prolonged infusion, as we discussed in the pharmacology module, to optimize its efficacy in the face of presumed gram-negative resistance. You, however, take into account recent data consistent with the occurrence of excess nephrotoxicity in association with the use of piperacillin tazobactam together with vancomycin and enhance monitoring of this adverse effect. Good antimicrobial prescribing does not end with empiric therapy. This is especially true for patients in the ICU and for those with presumed VAP. The diagnosis and antimicrobial therapy must be assessed daily to ensure continued appropriateness. 48 hours after the initiation of antimicrobials, your patient's condition has improved. She has less production of respiratory secretions, and her ventilator support requirements are decreasing. She has been afebrile for the last 24 hours, and her white blood cell count is 13,000. Her blood cultures have not grown any organisms. Her endotracheal aspirate culture has grown 2+ Pseudomonas aeruginosa. Antimicrobial susceptibility results show that this organism is susceptible to cefepime, piperacillin tazobactam, and aminoglycosides, but is resistant to fluoroquinolones. Let's evaluate this data within the construct introduced earlier in this course. First, does the microbiologic data make sense? Yes. This culture most likely is indicative of an infection. Pseudomonas aeruginosa is a common cause of VAP, and this patient had symptoms and signs suggestive of this diagnosis. However, clinicians must also consider that some cultures obtained through endotracheal tubes in mechanically ventilated patients represent colonization instead of infection. Many times, when a mechanically ventilated patient becomes febrile or becomes clinically unstable, multiple cultures from different sites are obtained to determine the most likely source of the fever. However, clinicians should not prescribe antimicrobials to patients lacking clinical signs and symptoms suggestive of pneumonia, even if an endotracheal aspirate culture is positive. And cultures from endotracheal aspirate cultures should generally only be obtained when clinically indicated. The wise use of antimicrobials requires that clinicians appropriately modify their empiric choice based upon new patient-related data, such as the results of diagnostic tests and the patient's clinical status. In this case, the decision is relatively straightforward. The patient shows signs of clinical improvement, and you have a microbiologic data available to optimize her antimicrobial regimen by de-escalation. MRSA has not been isolated from culture, thus vancomycin can be discontinued. This Pseudomonas isolate demonstrates susceptibility to several different antimicrobial options. The 2016 guidelines do not recommend one agent over another for definitive therapy to treat VAP due to Pseudomonas. Instead, the guidelines recommend using antimicrobial susceptibility testing to guide management. Monotherapy with aminoglycosides should not be used. In this case, since the patient is improving on piperacillin tazobactam and there is not a significantly narrower spectrum agent available, you decide that continued monotherapy with piperacillin tazobactam is appropriate. Switching to cefepime would also be reasonable. Next, assess for adverse effects of antimicrobials. Her renal function is stable, and no changes are indicated in the dosing of piperacillin tazobactam at this time. Finally, determine the appropriate route and duration of therapy. The appropriate duration of therapy must be determined for each patient and each infection. In response to accumulating evidence, the 2016 American Guidelines strongly recommend limiting the duration of antimicrobial therapy based upon the available evidence to 7 days for most patients instead of the traditional 14 days of therapy. They do not make a distinction between pathogens causing VAP. Some patients may require a shorter or longer treatment course depending on the clinical scenario. For example, a shorter course of therapy may be warranted in those with minimal ventilator requirements who recover quickly. A longer course of therapy may be warranted for severe infection with slow clinical improvement. Many institutions have implemented algorithms using procalcitonin measurements, and these can be used as a tool in assisting in the decision to discontinue antibacterials. Please refer to the compiled resources at the end of this module for further learning about this topic. Guidelines recommend a number of basic interventions to prevent VAP in intubated patients. These include but are not limited to the following: minimizing sedation, assessing for extubation readiness daily with, for example, spontaneous breathing trials, minimizing pooling of secretions above the endotracheal tube cuff, and elevating the head of the bed to 30 to 45 degrees. Although a full discussion is beyond the scope of this module, we encourage clinicians to incorporate these preventive measures in their standard work. Other approaches have included oral decontamination, gastrointestinal decontamination by enteral administration of non-absorbable antibiotics, and even systemic antibiotic prophylaxis. The latter two approaches, however, raise concern regarding their effect on the microbial ecology and the emergence of antibiotic resistance. VAP is a significant problem, and the optimal management of these patients is critical in order to optimize clinical outcomes and slow the emergence of resistance in your hospital. VAP management also illustrates some key concepts critical to the optimal use of antibiotics. These include obtaining cultures in patients with probable VAP prior to starting empiric antimicrobials. This information will be critical in both making subsequent management decisions for that patient, as well as understanding the prevalence of antimicrobial resistance in your institution, which will inform empiric treatment choices. Given that most VAP is due to nosocomial pathogens, broad-spectrum empiric antimicrobial therapy is often necessary. Access to institutional cumulative antibiograms can inform empiric antimicrobial decisions. Commit to reassessing antimicrobial therapy in response to microbiologic and clinical data, and de-escalate to the narrowest spectrum antimicrobial possible. The recommended duration of treatment for VAP is 7 days. However, treatment courses should be tailored to individual patients. Biomarkers, most notably procalcitonin, can be employed to help make this decision. Both the under and over treatment of VAP can have detrimental consequences for individual patients and the emergence of resistance in your hospital. Routinely employing these principles in the management of these patients will improve the quality of care you provide to your current and future patients.